Hello, I'm Ethan, and I will be your moderator for tonight's podcast. Good day to you, listener, and welcome to the pilot episode of Mental Health R, a podcast launched by MentalHealthPH. With the aspiration to achieve a stigma-free society that embodies empathy and unconditional care for the mental health of the self and others, the Mental Health PH team, together with Lighter Way and Silakbo PH, would profoundly share its advocacy with its listener, providing tips, information, ideas, and thoughts through a wide variety of topics to be discussed in episodes of Mental Health R. Launching our very first episode as we recognize September as Suicide Awareness Month, we bring you Keeping Lights Inside the Tunnel, a podcast on overt manifestations of suicidal ideation and how to approach this properly with the consideration of a carer's perspective. Carers are termed as anyone who provides any form of support to those who are experiencing mental health difficulties. These people are often exposed to negative emotions and are at risk of experiencing similar difficulties with those that they take care of. Often, these people are overlooked in the picture of mental hygiene and even in general mental health team. However, through this podcast, the Mental Health PH, Silakbo PH, and Lighter Way attempt to understand these carers by listening to their perspectives and thoughts. For this podcast, we have Dr. Ronald Del Castillo, a professor and researcher in University of the Philippines, Manila, College of Public Health, and also a carer to help keep us the lights in the tunnel. Good evening, sir.
Good evening.
How are you?
I'm doing well. How are you?
I'm quite anxious, frankly.
That's our. We can talk about it if you want.
But anyway, to start off, sir,
Sure.
Can you tell us about your history on providing mental health service to anyone or to an institution, and any experiences, sir, that we'd like to focus on, especially in depression and suicide?
Sure. Let's see. Where do I start? Well, I trained mostly in the U.S., so not mostly, all of my training, my clinical training was in the U.S. And so most of the people that I have worked with are usually people that we know are either disadvantaged, right? They don't have insurance, they're impoverished. Many are new immigrants, including Filipinos, who moved to the U.S. But I've also worked with college students. For instance, my postdoctoral fellowships in Boston was in a university counseling center. So all of my clients that I saw were college students. So needless to say, fairly or unfairly, depression and anxiety are what we call the bread and butter of the clinical psychology profession, because it's the most common mental health problem out there. And so I would say the most significant number of people that I have seen in therapy reported some kind of depression, whether it be major depression or related to that, of course, is bipolar. But to answer your question also on suicide, I've worked with severely depressed people and who have had history of suicidal attempts, suicidal ideation, and working in a university counseling center as well as a hospital, as a clinic in a hospital, also in Boston. You know, sometimes you're on call, just like any medical professional. So sometimes when it was my turn to be on call, you would get phone calls, including from students who are thinking of killing themselves. You know, you get phone calls in the middle of the night, so you have to handle that.
Sir, regarding, sir, your background, sir,
Sure.
is your work experience, sir, based on America or abroad, or are you referring, sir, on your work experience here in the Philippines?
That's a good question. No, my work has been in the U.S. Because after my doctorate and then in my MPH, I came back here to do mostly teaching and research. So I don't currently practice here. I'm considering it maybe in the near future, but my focus after I moved here has been to teach and especially to promote mental health in the public health context.
Okay, sir. How long have you been working here, sir, in the Philippines?
Yeah, officially since March 2015.
Since March. Okay, sir. Going back, sir, in lieu with my previous question.
Yeah.
How would you, sir, describe the mental health status of parang I mean, sorry. How would you describe the mental health status of those from abroad or in America compared, sir, with that of the mental health status here in the Philippines?
Sure. Yeah, it depends. I mean, at the end of the day, we all have the same feelings. Like sadness is the same no matter what culture you're from. Sadness, anxiety, all of those kinds of things. What we call as depression or an anxiety disorder might be different because of the nomenclature, right, of whatever diagnostic thing that we have used. But in my experience, it's not different. I have seen students here at UP, who I know have depression or who I know have bipolar. So it's not the same. It's not different in that sense. I think if we can get to the nitty-gritty, there might be some differences. But the difference is usually in our approach, in how we deal with it, and how we work with it. So here, it's probably more, as you very well know, it's probably more social in our approach, right? So we might involve the family, we might involve peers, that kind of thing, which is less common in the U.S. But I think also an important difference is the system itself, right? The U.S. has more resources, and therefore many of the people that I've seen there have many resources. Even those who have limited resources have more resources than many Filipinos here who are well off. So I think the problems are more or less, in my view, the same. But how to address those problems is what's really the significant difference.
Oh, sir, you've mentioned, sir, earlier that feelings are mostly the same and it's not that different between those of the Americans and the Filipinos. So, sir, however, I want to point out, sir, that can you please describe, sir, that how does a Filipino experience depression or a suicidal ideation? Like,
Sure.
Can you describe what are its manifestations?
Sure. I think part of me wants to say that in some ways it's not different. I think it's hard to talk about. I think among Filipinos, and it's hard to talk about for anybody, regardless of what your culture you're from. I think in that sense, it's very much hidden. There's a sense of shame. There's a great deal of stigma that comes along with it. Perhaps even embarrassment. Perhaps in Filipino culture, it might also manifest as physical symptoms. I have a headache, my back hurts. Even though it might suggest actually more of a psychological or emotional problem, we describe it as physical. I think but a part of me wants to say also, again, it's not different because many, especially young generations, such as yourselves, you grew up heavily influenced, if I dare say, heavily influenced by Western culture, especially American culture. So there's a part of me that wants to say, yes, there is that element, I think you and I discussed earlier before our fun podcast here about Psikologiyang Filipino. But you also grew up very much with the internet and Facebook and all these many quote-unquote Western things. And so to me, that colors your experience of depression. So that's why there's a part of me who wants to say, it's not really that different. Yeah, there's that core feelings of sadness, the core thoughts about, in worst cases, thoughts of worthlessness and guilt, and then thoughts about death. And I think... But here, I think the core difference is around the issue of stigma and the shame and around it and the hesitation around having an open discussion and about it.
Yes, sir. Earlier, sir, I believe, sir, that you have described yung symptoms of depression, like physical or physiological experiences, like headaches, back pains, or yung mga subjective feelings sir na refusal to go to sleep or yun nga yung you said earlier yung pure sadness and stuff. How do these symptoms of depression translate to a suicidal ideation? Would you sir that say that all depressed people or all people with depression have suicidal ideation?
Oh no, of course not. Of course not. No, of course not. The suicide is common, but it is far less common than depression. Depression is very common. That it far outstrips suicide, even though suicide might be common.
Yes,
right. So it's important to remember that the line between depression and suicide is not a direct route. Right? And vice versa. There's considerable research to show that people who are suicidal are not depressed or do not have any sort of mental health problem. They're suicidal, but they don't have a mental health problem, if you can believe that. But there's evidence to suggest that. Meaning, and that changes the way we approach suicide, right? Now, how does one get from depression to suicide? Many factors, both internal and external. Of course, people who are severely depressed are at higher risk. People with a family history of suicide, people who have had significant losses in their life, especially in early childhood. People who have, who've had a recent event that's very important to them and that created conflict for them. And that could include a breakup, or that include a loss of a job or whatever it is, getting fired from a job. Those are important triggers. It's hard to say because part of it is also internal, right? I might be very depressed. I might be thinking about death, but my coping skills is such that, no, I'm not going to go there, right? There are many ways to get to the actual attempt. From the thought to the attempt is a huge gap, right? And most people are only in the thought part. But the attempt part is a much smaller number still from the thought part. Yeah.
So sir, let's see sir na you have said also sir that there's a gap between the thought itself and the attempt itself, sir. So considering this gap, sir, do you think, sir, I think the answer to this question, sir, is more or less obvious. But are these thoughts or the depressive moods manageable, sir, for the person experiencing such things? If it is manageable, sir, by which means are they manageable?
Oh, of course, yes. I mean, I have to be hopeful. I mean, in the profession that I'm in, of course it's manageable. Of course, it's absolutely manageable. And there are many, many ways that it can be manageable. That's both coming from the individual, from the resources of the individual, as well as the resources outside the individual, right? For instance, something as what we call self-care, like important things or basic things that people who are severely mentally ill or depressed ignore, like taking a shower or eating or watching TV or reading a book. These things we might take for granted, but remember, for people who are severely depressed, it's too exhausting to get out of bed. It's too much effort to eat. It's too much effort to go to work or to go to school. So even just meeting that basic approach is a way to manage something, right? Another is to what we call graded tasks, where we break down something that's seemingly impossible to do into smaller tasks, right? And so, for instance, like taking a shower, like that's a lot of effort for someone who's severely depressed, right? So maybe today we won't take a shower directly. We'll just go to the bathroom and then go back to bed. Right? And then maybe we'll open the shower curtain the next day and then we'll go back to bed. The point there is that you break down what seems like that's so much effort. Exactly. Into lower, yes, exactly. Another is what we call developing a wellness toolbox. A wellness toolbox is essentially a reminder of what you like to do in your life that perhaps you have neglected because you've been depressed. So that means, whatever's important to you. That could be watching a movie, being with your friends, taking care of yourself. I, for instance, I yoga, I meditate, I like to bake. I know when I'm stressed because I bake a lot. I like to cook. I like to watch the Asian food channel, like that kind of stuff. These things I sometimes forget because I'm caught up with my work and my stress and all of that. But I go back to those basic things to remind myself that it is manageable. To me, the most basic things are foundational, and they're foundational for a reason because they work. All right, so we didn't even get to go see a psychiatrist, go see a psychologist, go take a medication. We're not even there yet. We're just trying to take care of yourself, and that I think is very important.
So you're saying, sir, that even those who are experiencing depressive episodes or who are experiencing symptoms of depression can still take care of them.
Absolutely. Because I subscribe to the belief that people who have mental health problems should be empowered to dictate their own life, right? So I'm not in a position to should tell you, oh, you should do this, right? For me, I'm a big believer that what do you want to do, right? What do you want to do?
So like support.
Absolutely.
Support
So
them.
absolutely.
Absolutely.
I'm a big believer that just because you're mentally ill or a mental health problem doesn't mean you can't do stuff with your life, including getting a job or going to school or whatever.
Yes, right, I agree. And like, sir, what I've said earlier now, in this podcast, we would explore, sir, the role of non-professionals on supporting these people who are experiencing depression, and most especially, sir, those who are having suicidal thoughts. Can you, sir, describe or elaborate what are there? Kanina, sir, you have said na yung they should be able to support these people. So, sir, now I would like you, sir, to elaborate further. Kung how will they be able to support? Like, can you please give examples on specific activities or that they can support the
Sure, yeah. Well, I think one of the important things is to know your role, know what you can and cannot do. If you're the non-professional, then don't act like a professional. Don't act like you're gonna be saving the world, because that does a great disservice to you, and it certainly does a great disservice to the person you're trying to help. So for me, first thing to know is know what your responsibilities are. You know what role are, and most importantly, know what you cannot do and should not do, and leave that to the professionals. Right? That's number one. And number two, there's plenty, of course. There's plenty. That could be as much as being Again, I go back to the basics, and they're basics for a reason because they work, right? And that includes listening, like active listening, and I mean actual listening. When people listen, they're only half listening because they're getting ready to respond. When you're getting ready to respond when someone's talking, you're not listening because you're getting ready to respond. So active listening is not getting ready to respond. It means actual listening, right? And that takes a lot of effort and it takes a lot of work. That's one. Number two, encouraging people to get to decide what they want to do. And I mentioned this very briefly earlier. What do they want to do? Like literally, what do you want to do? Do you want to stay home? Do you want to try to go to school or work or whatever? Instead of dictating what to tell them, we ask questions about what they want to do. Because I'm a big believer that they should be active. People with mental health problems should be actively involved.
May I ask you a question regarding that?
Sure.
What if, sir, the person doesn't really know, like kanina, sir, you said that it takes a lot of effort for people to go out of bed. So I believe, sir, that, and in my case, sir, I've also encountered people who are experiencing these symptoms. It's hard for them to distinguish what they want to do. So how can we encourage them to do things if they don't really want to do?
Let me ask you. Okay. For me, the issue there is not them. If I can be frank, the issue there is you, because you want them to do something.
Okay, sir.
Maybe they don't want to do anything, and that's perfectly fine. So that to me is the issue. The issue is not that they don't want to do anything. The issue is that you want them to do something, right? For me, that to me, empowerment means including the decision to say no, right? So I want to be in bed. Okay. When you're ready, you let me know. And they may never be ready. And to me, that's perfectly fine. Short of them hurting themselves and hurting other people, you go right ahead. In my experience, that tends to work more because they are more likely to be on your side once you stop pushing them. And that means all right, you let me know. When you're ready, I'll be here and we can do whatever it is you want. Right? For me, I have found that the anxiety, the worry, is not coming from the client or patient. It's coming from the professional or the person trying to quote unquote do something. Right? Because they feel like if nothing's being done, then something is quote unquote wrong. You have to entertain the possibility that part of intervention is doing nothing. And to me, I think that's equally important.
So that's like also supporting them, am I right, sir?
Yes, absolutely. Yes, absolutely. The absence of the intervention is an intervention.
It's an intervention.
Yeah, in the same way that in therapy is not just talking. Therapy is about listening as well as silence. Not saying anything in therapy is therapeutic.
Yes. Basing on your answer, sir,
Sure.
What is generally, sir, in your opinion, the right approach
Sure.
a friend or family should be able to do to a person experiencing depression or having
Sure.
a suicidal ideation? In other terms, sir, how to fairly communicate with a person who is having suicidal thoughts?
Yeah,
Because I think, sir, maybe some families might be frustrated that for a long time wala po nangyayari with the person or with the relative. So how can you address this concern of some or most, let me say, most families?
Sure. Yeah, I think that's completely understandable. I think if you're a loved one, if you're a parent, I think the number one job of a parent is to worry, right? And I think when you see your child or a loved one sort of struggling and having depression and maybe thinking of suicide, you believe that they might be thinking that. I understand why they want to intervene and want to intervene right away for the safety of their own child. But I go back to my point earlier. The more you push, the harder people pull back. And that's hard to reconcile for people, especially parents who want to reach out. But that's not to say that they shouldn't reach out. So I go back to what I said earlier. I think there's a lot you can do. There really is, including letting your children know, or whoever it is, your loved one, whoever it is that's important in your life, that I'm ready for you when you're ready. All right, and that there are certain support systems that can be provided to them, right? Whether it be a number or, I have told parents before that, it's hard for your kid to talk to you about this. Maybe you know someone or they know someone they might be more willing to talk to. So there could be a grandmother, a grandfather, an aunt, and uncle that they might be more comfortable talking to. And that's great, I think. Excuse me. I think that's another approach. Another way is to provide concrete connections, such as, the hope line, those kinds of things, so that letting the children know that there are available resources, options to them if they don't want, I know you don't want to talk to me, and I totally get it, but here's other avenues in case you want to talk to anybody, right? And I think that's equally important as well. And for the parents to also seek guidance from other people that are important in their life, whether it be clinicians, other parents, or religious leaders, or church groups that they might belong to, that's helpful. I think that's another way to do it.
Sir, with everything that you've told me, sir, can you, especially sir, the approaches, I really appreciate sir yung approaches that you shared before. Can you share sir an experience that that is memorable sir to you, wherein these approaches really significantly, I mean rather significantly help sir the individual who is having mental health difficulties? Can you please share an experience?
Sure. A part of this I acknowledge is because of my own clinical training. I've worked with people who want to hurt themselves, and I've worked with people who've attempted to kill themselves and did not. It did not work out for them, if you will. When I was doing my clinical training in Boston, I had one senior, fourth year student in college, who had a difficulty with her roommate. She was staying in a dorm. That's what the problem she was coming in. She was having problems with her roommates. She lived with like 3 other girls in her dorm. And so she wanted to figure out how to deal with them, right? Among the 4 or 5 of them, she was the one who felt excluded in her dorm. As it turns out, a couple of sessions later, it became clear that she was depressed and anxious, as well as obsessive compulsive. She liked to clean for 2 hours every day, and the tension among her roommates was usually that she felt like the other roommates were not cleaning, or at least it was not clean enough, at least according to her. So the dishes or the room, whatever, were always dirty, according to her. And so imagine cleaning for 2 hours every day before she can do her homework. And needless to say, she would stay up all night doing her homework because she spent 2 hours cleaning before doing the homework. And so it came out that she had the core of her issue was a poor relationship with her mother. She was most likely to clean after she had just had a conversation with her mom over the phone. But in any case, she was severely depressed, where she wouldn't go to classes, and she was about to graduate. So in a way, she couldn't afford not to graduate, right? I started seeing her at the beginning of her 4th year. She was also cutting her wrist as well as her legs, their hair in their thighs. Let me repeat that. She's depressed. She has anxiety, including obsessive compulsive disorder, and she cut. But the main reason why she came in, at least the triggering event, was the fact that she thought about killing herself, and that was the first time it had ever occurred to her, and it had never occurred to her before, so she got scared, and that's why she wanted to see a psychologist, and hence how she came to me. I assessed her. She had no intention of dying. She had no plans of dying, and she had never attempted to die. But the thought of dying, of her own death, was the first time that it ever really occurred to her, and that scared her. Now, I can tell you from experience that depression, obsessive compulsive disorder, and cutting are hard to address in a 9-month period. It's even if I see them regularly, like once a week, it's difficult. And so our goal was not to quote unquote fix the problem, but to get to the problem where it is somewhat manageable. Okay, so what does that mean? That means getting the 2-hour cleaning to 1 hour, right? So it's not 2 hours to 0, it's 2 hours to 1 hour, right? So instead of cutting every day, let's try to keep it at 5 days a week instead of 7 days a week. Notice I'm not telling her to stop cutting, like short of her own safety and of course the safety of others, which I always assess. She liked to cut because it was her way of coping, right? So to take away her coping would be more damaging. So in addition to reducing the coping, the cutting, we learned how to cope, including how to carry a healthy conversation with her mother over the phone, and her mother was always her trigger, right? So again, notice how these are sort of basic approaches, including um, giving her what we call in psychology a new experience, meaning she had always felt rejected by other people. That quote unquote she was never good enough. It's part of the relationship with her mother and manifested with her relationship with her roommates. But every time I saw her, I made sure that she did not feel rejected. Right? So whenever, for instance, if she misses an appointment, I told her that it was okay and that when she was ready to come back, I'll be here. So instead of yelling and like, oh, you missed your appointment, blah, 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 because if I did that, what would I be doing? I'd be like her mother and I'd be like her roommate. Instead, I give her a new experience that no matter what she did, that she was not going to be rejected. Wrong or right, quote unquote wrong or right. No matter what she did, she was great and perfect the way she was. And that's the new experience in therapy. And so at the end, she was still somewhat depressed, but she got down to an hour of cleaning, and she cut herself once a week. See? So notice that we're not curing the world. Of course, eventually, I want her to be at her maximum health, right? No depression, no cutting. But that's not realistic given the fact that I only saw her for 9 months. I think that's an example of, for me, how basic experiences can be helpful.
Sir, I really appreciate, sir, yung story. But going, however, sir, can I ask, sir, if this approach can also be assisted or initiated, sir, by someone who is not really a professional?
Oh, absolutely. I mean, I know I have told you nothing I have told you nothing that requires a license. You know what I'm saying? These things we can do with sufficient training that doesn't require a doctorate or a license, right? When people do things we don't like, what do? We reject them, right? We yell, we get upset. Totally fine. Of course, that's a valid experience on our part. But you have to imagine someone who feels rejected, who feels like they're rejected for much of their life. You are repeating the same behavior that they've experienced, right? So for me, that's why it's important. Whenever you're ready, you let me know, and I'll be around. Or even like, you know, I mean, an intervention is just spending time together. That's an intervention, right? So I think absolutely, I'm a big believer that anybody can do it. Yeah.
Sir, pero sir, if the scenario, sir, is like what similar, sir, to your
Sure.
clients or before, what are the steps, sir, or the approaches that her or her relatives or her friends could have done to guide to maximize the experience, or the experience, sir, that she's getting better. Am I making sense? But parang ganun, sir.
Yeah. Well, let me ask you something. I know you were asking me questions, but let me ask you something. What do you imagine would be one thing to do for her in that scenario, or her family could do, or her roommates in this case? Like, what could they be doing?
Actually, sir, in my opinion, sir, if her roommates are considering, sir, if her roommates are her friends, she could have accompanied her to her sessions, or could have talked to her, like ask her to open up if she would like to open up, or would like to join her in things or in activities.
Yeah. Absolutely. And all of that is perfectly valid.
Like parang the intervention is really holistic, that it does not just occur inside the office or inside the clinic.
Yeah, no, absolutely. And it's not, but first, I think it's important to step away, and this goes back to what I said earlier, in terms of role, like what your role is. Is your role being a clinician, or is your role being a friend, right? So, a friend would not do an intervention. A friend would be a friend, including, I'm free today. If you want me to walk you to your counseling thing, you let me know. I'm a text away. See, that's not an intervention. It's what a friend does, right? So that's why I always go back to understanding your role and your responsibility. And I do this to all my students that I encounter here, especially here at UP. My role is to be your faculty and your professor, and not your friend. And this is very minuscule. This is why we're not friends on Facebook, because my role is to be professor and faculty, right? So I'm very cognizant of my role, as well as I recommend other people. So yeah, everything you said is perfectly great. Yes. You want to talk tonight? You let me know when you. And for me, the more important part is, what do they want to do? What do people in your life who are going through mental health problems, what do they want to do? You don't know that until you ask, right? And including, if they don't want to do anything, all right, then let's do nothing.
Sir, pero how about, sir, that if they care, sir, in considering, sir, a holistic intervention, sir, with what I have said earlier, what do you think, sir, I think, sir, that you will agree with me that in this picture, it's not only that the person with depression or the person who is suicidal is the one should be considered, but also the carer.
Absolutely,
in terms, sir,
yeah.
The carer might experience burnout.
Absolutely.
How do you think, sir, this concern should be addressed, or how could a carer take care of himself or herself so that she or he could be able to take care?
If we believe in a holistic approach, that means what we tell people with mental health problems should also apply to us. Because they're not different. There's no difference. If we treat mental health problem as any other physical illness, then therefore the recommendation should be no different. Meaning that everything I just told you applies to you. Having a wellness toolbox, seeing friends, getting some sleep, eating right, all of that applies to you. So what you want your loved one to do as a mental health problem, what you want them to do applies to you as well. So it's not unique, there's nothing new for me to tell you, because what the approach for me is mental wellness, right? So that applies to anyone, regardless of whether or not they have a mental health problem, right? So it could be that, you talk to people in your life, right? Hopefully you have social supports, other family members, other peers as well, right? But notice how that's not different than when we ask people in their life with mental health problems to do the same thing. Oh, you should try to do this, blah, blah, blah. So to me, the recommendation is still the same. Grade a task, the wellness toolbox, trying to take care of yourself, having people in your life, having social support, blah, blah, blah. Accessing services that might be available to you, whether it be counseling in your school, at work, or talking to church people in your life that might be helpful, or your own parents, right? You might be a parent, but you have parents as well. You might have parents in your life already. So yeah, it's the same thing.
Sir, yes, I agree, sir. It's the same thing, sir. But I have to point sir out that taking care of someone who is experiencing depression or any mental health difficulty is really demanding to the mental health of the carer.
Yeah.
So, can you give, sir, any tips to?
Let me interrupt you there for a second. It is demanding. Absolutely, it's exhausting. A little self-disclosure. Part of the reason why I'm into mental health and got into the clinical psychologist profession, because I grew up with an aunt who was schizophrenia and had mental retardation. She has since died. She died a few years ago. But I had always known her to be psychotic, and I had always known her to have mental retardation. And I am sure it was exhausting for my grandparents. I'm sure of it. But the difference was my aunt grew up with 9 other siblings. And my grandparents were surrounded by family. And so my aunt was never institutionalized. She was always home. And she was always supported. And died with 100 people around her. right? And that's how I came to understand mental health. That just because they have mental illness does not mean they should be institutionalized. They will always be home and supported, right? I mean, if she probably would have been volunteering and doing some sort of work on the side because she had mental retardation, so that was a little complicated. But my point there is that when you feel exhausted because you're taking care of someone, right? That's totally understandable and expected and perfectly normal. Now, when you're feeling that, use that as a jumping point for empathy towards your loved one. Because they too are exhausted. They're exhausted in the hole that they're in. They're exhausted, they want to get out of this depression or anxiety or whatever it is. The weight is too much. You have to imagine how that sounds like the experience of the carer. So you have to imagine what that's like for the loved one who actually has the mental health problem, right? So for me, first, use that as a jumping off point for empathy. So the next time you try to say a loved one, oh, go shower, go eat, go to school, when you're exhausted, you have to imagine what your loved one is going through, right? So again, that's a place of empathy for me, right? That's one. But number two, I think once we come from that place of empathy, we have a better understanding that what best works for the loved one who has mental health problems is not necessarily always what we think is the best for them, right? We think what's best for them is because we think that, oh, this works, right? Because we think that we're trying to take care of them in some way. But I think it's important, if you start with empathy, you'll realize that perhaps some of the things you're doing is actually not the most helpful thing. That's really morbid, isn't it? Yeah, but I think it's important. I think that's a jumping off point for a stronger connection, right? But for family members, I think surrounding yourself as well with people that's supportive of you is equally important. Because I know I've worked with people who are cared for, who are carers for people who are mentally ill. So it can also feel lonely, right? It can feel like a sense of burden and exhaustion. It really can. It really can, and it puts you at risk of developing your own mental health concerns, right? Because of this of this responsibility that you have. Yeah, I get it. Yeah.
This question, sir, is on my personal side.
Uh-huh.
Can I ask you, sir, that can a person having difficulty, like if they have a friend who is having the same difficulty, would it be healthy that they share stories, like they share their experiences? Would that be healthy? I think there's this
To whom? If you're a carer.
Yeah,
If you're a carer and you want to share your story with.
No, sir. Like for example, I'm also experiencing difficulties.
Okay.
And my friend is also having difficulties.
Sure.
Would it be healthy that we attempt to help each other?
I don't see why
Because
not.
I think, sir, that
Why?
there is based also from my experience, there might be notions that it might not be healthy because according to people it's like both of you are dragging yourselves down,
sure.
deeper.
Yeah. No, I understand. I see what you mean.
What's your take on that, sir?
I don't see why not. I don't see why you couldn't. Because to me, what the attempt there is not the conversation. The attempt there is connection. Wanting to connect, right? And so, wanting to connect with anybody is healthy, right? I think, right? Wanting to connect, so wanting to connect with someone who's going through the same thing, I think is also healthy. Right? I can see what you mean because I feel like oh, they're gonna go down this rabbit hole together,
Yeah.
right? Because they're suffering through the same thing. But I'm I don't subscribe to that. One, because I'm an optimistic person. I just feel like you have to give people credit instead of being so suspicious. It's possible that they're reaching out to each other, and as a matter of fact, when we talk about community-based mental health, right, and empowering people, and one of the core tenets of community-based mental health is that people who have mental health problems should be actively involved in the decisions about their lives. Because historically, right, there's that misperception that people who are mentally ill cannot make decisions for themselves, right? And so, but community-based mental health is also about connecting people with mental health problems to their peers, to other people with mental health concerns. Why? Both practical and psychological. Practical meaning that peer-based support groups are extremely helpful. Extremely helpful. Because precisely for the reason that you have gone through the same thing.
Yes.
Right? And
That's
that
right.
kind of experience is very powerful. It's extremely powerful. In the same way that, I know it might not be common here, but for instance, if you have a physical illness like cancer support groups are extremely helpful because they've gone with, for people who've gone through the same thing. So people who have mental health concerns is not any different. Again, the practical side there is, especially at a community-based level, is peers who have gone through the system can recommend or give ideas to other people who might be going through the system. That could be something as, oh, there's this doctor that I like at PGH, you should go see him. Oh, do you know that you are eligible for PhilHealth and these kinds of benefits, or GSIS? Practical information. Oh, did you know that there's housing available for blah, blah, blah? That I can tell you no academic or expert is going to know because we haven't gone through the system. Peers have. So that's the practical. And again, the social there is the fact that we have this common experience, and that can be very powerful.
Actually, sir, I really agree with you, sir. Like, above all that you have said, sir, I really think, like, I would like to use my friend's analogy in here. Like, it's like sharing the same sea, even though you're at a different boat. It's like you're sailing in this
absolutely, that's a good
ocean.
analogy. Yes,
Yes.
absolutely. Yes.
And that's just I really wanted to ask you that question
Sure.
because some people really think otherwise, like they have this negative notion
No, I understand. I understand. I see what you're saying.
in which that they don't really understand that. For example, I've gone through these same things that this person is going through. Maybe not identical, but in the same fashion.
Yeah.
And I believe that this kind of connection is really important. Like, it really makes someone feel less lonely.
Right. The more we treat mental health as, I always tell people, mental health is not special. There's nothing special about mental health. It's not unique. The more we treat it as like any other thing, the more we address this issue of stigma, right? So when I want to talk to you, right, because I have a mental illness, right, and you have gone through the same thing, and right, so yes, that's important, right? And there's nothing wrong with that. There's a connection. We have gone through the same thing. Now I gotta tell you, that's not different than you and I hanging out, having gone through the same thing. Oh, we went to the same concert together. We grew up in the same town. See how the same that to me that's totally the same. And why is that nice? Because we have gone through the same thing, right? We went to the same school together, right? It's the same thing. That feeling of connection to me is the same. It just so happens that, it's depression or anxiety. It's not different to me.
So with this, sir, I would like to take, sir, that with the carer, the carer who's trying to take care, like who had experienced this mental health difficulties in the past or maybe in the present, this experience with sharing this connection with another person would be very therapeutic on his side.
Absolutely. Oh, I gotta tell you. Yes. Social connections it's good. It's good. I'm hammering that point. Absolutely. Again, it's not common here, but an ideal sort of community-based level intervention or a prevention effort would be to get people together who are carers. we get together every Friday at our barangay hall station, and then we talk, we chit chat, we gossip. We don't even have to talk about our loved ones with mental from their home and being stuck at home and blah 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 and all of that. But it lets them know that they are not alone, and people with mental health problems feel so alone, and including the carers. And so to know that, you know what? I have other people here who have gone through the same thing. And we don't even have to talk about mental illness at all. We'll just hang out, have a popcorn, watch TV together. And that's powerful because the connection is there.
So, sir, I would can you please, do you have any message, sir, to any
geez.
care?
Okay. Care, to any care. Well, as I say this, I think about
Like, can you stress out their importance?
Yeah. No, I think about the experience of my grandparents, especially my maternal grandfather, because my grandmother died when she was young, and so it was my grandfather who took care of my aunt for much of her life. So to any carer out there, first I think thank you for your commitment, and I think I want to say hard work, but even that doesn't describe the amount of responsibility I think that is bestowed upon them. So first, our deepest gratitude to the carers who really push forward. Number two, as I mentioned just now, to let the carers know that they are not alone, that they have people who go through the same thing, and I recommend that they try to reach out to those people. I acknowledge that that's hard, I think, but I think I can assure you that wherever you are, you're not the only one. And so I think to reach out and maybe form a group together, casual group. It's not a therapy group. It's just a bunch of people hanging out, and I think that's good. That's number two. Number three, as I mentioned earlier, a place of empathy, right? A place of empathy is a good place to start, and a way to cope with the responsibilities of taking care of someone who's mentally ill. Number four, I mentioned earlier, whatever applies to your loved ones applies to you, including taking care of yourself, right? You want them to shower? So do you. Right? You want them to eat right? So should you, right? It's like it's a silly parallel example, but it's like a parent telling your kids to eat a vegetable while you're eating a chip, or a pizza while you want your children to eat vegetables. It's not good modeling, right? It's not good modeling behavior. So to the carers out there, whatever intervention or whatever you want to call it that's helpful for your loved ones is helpful to you, right? We talked earlier about graded tasks and wellness toolbox, doing the basic stuff. I think that's good. And there is no shame. There is absolutely no shame in asking for help. Whether that be a counselor, a psychiatrist, a social worker, your church person, it doesn't matter. There's no shame in asking for help. So, yeah.
Sorry. Thank you, sir, for
Sure.
sharing us your thoughts regarding this topic.
Sure.
Through this podcast, or through this episode rather, I would like to say that the importance of carers is really significant in providing a holistic intervention for his or her friend, or loved one. And more importantly, this is also therapeutic on the carer's side.
Sure.
Like having a similar connection, or seemingly sharing the experience. With that, sir, I would like to end with a quote that I really loved. A quote that I really picked from what you said. Like, a good place of empathy is a good place to cope. Okay. Thank you, Sir Ren,
Thank you.
for sharing your thoughts with us. Thank you.
I'm honored.
For the listeners, thank you, listener, for sticking with us until the end of this podcast. Next month, we will be looking into the mental health conditions of those in war-inflicted areas. Stay tuned for the October episode. Thank you, sir.
Thank you.
Again, this is Ethan, your moderator for this podcast, signing off.